Hey everyone, welcome to the Healthy, Wealthy, and Smart Facebook page. We're doing kind of a Healthy, Wealthy, and Smart live today with Dr. Sandy Hilton. She is a physical therapist and owner of Entropy Physiotherapy and Wellness in Chicago, Illinois. And she is a pelvic health physical therapist. And so today we're going to be talking about some common myths with pelvic health. Sandy has a whole bunch. We're going to break it down. We'll give maybe the top 5. And then we'll talk about the need for some simplification in treatment of these patients because maybe they're not as complicated as we make them out to be. And of course, if you're listening to this, you're experiencing pelvic pain, this in no way replaces individualized physical therapy care or medical care. So if you are having pelvic health issues, then go to the section on Women's Health website and look up a pelvic health therapist in your area. And we'll put the URL for this section on Women's Health underneath this video when we're done. So, Sam, welcome.
Thanks, Karen. It's always great to come on and talk. Somewhat of a passion for me.
Well, that's why you're here, because you know so much more about this than I do. So let's get right into the common myths. So I know you had like a whole bunch. We're going to break it down into maybe the top 5 common myths that are surrounding pelvic health, pelvic pain, dysfunction. So I'm going to have you take it from here and start with myth number 1.
Okay. It's one of the ones that bothers me the most that I hear in the clinic is people who've been told they need to give up that very thing that they love to do, specifically around exercise. So if you're having pain in your bladder or with bowel movements or anytime you sit down or when you're trying to have sex, that's a scary, hard enough thing to deal with. And like any pain or challenge, there's rehab that can help you. One of the things we need to be really careful with is not to say things like, you'll never be able to run again, or you'll never be able to ride a bike again, or you'll always need to sit on this cushion. And that's just not true. The always statements are things to watch for, because all it takes is one person who has come through having pelvic pain and bladder problems to get back to things like rock climbing and running and, I don't know, crazy yoga on paddleboard things to disprove that. So it might be hard, it would be challenging. It's certainly going to be an individual path, but to say you're going to have to give up the things you love now that you have these problems is kind of why physical therapies exist, to make that not true.
Okay, so kind of be on the lookout for the always or never, ever kind of statements.
Right.
Okay.
And you can get your life back. Yeah.
And I think that's important to know, and I think it's important to instill that into our patients and for people to know that there is hope for the good majority of people.
Yeah, the stealing of people's hope, I think, just makes it harder. It's hard enough when you hurt. To take that away from someone is not nice.
Yeah, it's cruel. It can be cruel. Okay, so that's myth number 1. What's number 2?
Myth number 2. When people talk about pelvic pain, it always comes to get blamed on either your psoas or your pudendal nerve. And it is.
You mean it's not the psoas? I thought the psoas, isn't the psoas like the energy system of the body?
It's everything. It's a very busy set of muscles in there, but it is not. Neither the psoas nor the pudendal nerve are the cause of all pelvic issues. And sometimes you can get on Dr. Google and get very scared and think that the only way out for you is a surgery that cuts the ligaments that the pelvic nerve, or pudendal nerve runs through after it comes off the spine and before it gets to the pelvic floor. And that's not true either. Those surgeries are less and less often being done because the outcomes tend to be just around 50%. And it's not really what you do for a lot of things. Although I do know that for some people they are successful, and for some people they are so desperate to get help that they go for the surgery anyway. But the biggest one here is that it is not always your pudendal nerve. And if you rule out your pudendal nerve, it is not your psoas. Although
So the psoas, for people who maybe aren't familiar, is also called your hip flexor muscle.
mm-hmm.
Just in layman's terms.
It's deep in your belly, and one thing that happens is that when we hurt, we tend to kind of crouch forward a little bit and protect ourselves. Especially if it's your lower belly and pelvis that hurts, we fold up a little into that fetal position. That's what that hip flexor muscle does. So if it stays a little bit working all the time, it's going to be sore when someone touches it. That doesn't mean that's why you are having problems. But it's nice to get it all worked out and happy again. Just don't blame it. It's fine. It's just in there doing its job.
Okay. All right. So don't always blame the psoas. Don't always blame the prudental nerve. There are actually other forces at work that can be causing pelvic pain or dysfunction.
Yeah, and a good physician that's familiar with pelvic issues and a good physical therapist that's familiar with pelvic issues can help you sort through what's really bothering you. That's why what Karen said in the beginning of this is so important. This isn't a one-size-fits-all. There are principles that we follow, but there's not a protocol. And that's okay. Sometimes that seems like it makes it more complicated, but it doesn't. It's just that you and your health professionals are going to need to do a little bit of investigation and trial and error.
Okay, that makes perfect sense to me. All right, so that's 2 myths down. Let's go to myth number 3.
It is totally safe to exercise. So one of the other myths is you are too fragile if you have pelvic pain or incontinence or other problems that you cannot exercise. You need to just walk carefully and be very careful with your body because it's fragile. And that is not true. In fact, we know that one of the things that gets us better is getting stronger and moving more, not less. So it is.
And that's huge because we don't want people to fear exercise and fear movement and fear, or I should say not fear, but not trust in their body. Because if you think you're fragile, it's a really awful place to be when you think any little movement is going to make it worse, or not even any movement's going to make it worse. And I know this from experience is you're going to make it worse. You're going to be the cause of making yourself worse.
Right, and something that you do is going to make it get unable to get better. And that's not true. Part of that comes from the mystery of the why me for the person is why did this happen to me? And all of the machinery and all of the tests and great people can't always answer that question. What that does, I think, to a person is they keep wondering, well, if I don't know how this happened, how do I prevent it from happening again? Mm-hmm. And even if I'm getting better, how do I know that this isn't just going to happen again if you can't figure out how it happened in the first place? And that's a really great question. But one of the things you can do to build a bigger buffer around yourself is reclaim that confidence, like you said, that you're resilient and strong and you're able to do things and do them.
Yeah, and I think it's important as the healthcare practitioner to be able to very thoughtfully and thoroughly explain that to your client or to your patient, because there is nothing worse than thinking everything you do is making you worse.
Right.
And it's a bit of a rabbit hole, you know, you can kind of keep going down and down and down, and then you don't want to do anything.
And like, it's scary, right?
It's a scary place to be, and nobody wants to be. No one wants to live their life that way because all of a sudden you've just stopped.
Right, and it's like your world has gotten very, very small.
Yeah, exactly.
And we try and help people reclaim that territory and confidence around it. But it is scary. It is hard. And then you work out and you're sore. And we need to also explain to people that soreness from exercise is actually a really good sign. It means you did something and your body's going to get stronger. Do it again.
Yeah, absolutely. Absolutely. And, you know, every time I hear about these kind of stories of being afraid to exercise, being afraid to do things that you want to do, it always brings me back to when we were in Disneyland. And we got to, you know, waiting in line for however long for what I thought was some sort of a jungle. And as it turns out, we get up there, it was like, if you have neck or back issues, like danger signs and all this stuff. And I was like like started sweating. I mean, I looked at you and Sarah, and you guys looked at me, and you were like, okay.
Very good. Yeah, they always have that on all of those rides. If you have any back issues, neck issues, if you're pregnant, you'll get off here, a little emergency exit.
Yeah.
And it was not bad, was it?
No, it was not bad. But going in, I was like shaking, sweating, like palm sweating, and what you and Sarah did was exactly what you just said. You kind of helped me reclaim some confidence in my own body, as well as the fact there was a 5-year-old going on in the same class with me. So, I mean, he can do it, I can do it. But it was more of the looking at things from a very practical standpoint and instilling some confidence in me so that I can get on, which I did. And I was fine. And then I was able to get on another ride. Yeah. But if I didn't get on that ride, I wouldn't have been able to do anything else for the rest of the day. I'd be sitting with the dads in the beer line, you know?
Which is not a bad place to be, but just because you want to be, not because you think that's the only thing you can do.
Exactly. All right. So it is really important and to know that it's safe to exercise and safe to move and safe to do the things you want to do.
Right.
Okay. So that was myth number 3. What's myth number 4?
Okay. Myth number 4 is the concept that pelvic pain is because you are out of alignment or because you use the wrong posture or there's some mechanical fault that is creating this problem. It's just not based on any evidence. That would require severe trauma, like a car accident, to disrupt your sacral ligaments. They're strong. Your sacrum's not going to go out of alignment.
It doesn't just pop out like Tiger Woods said his sacrum was popping out all the time.
Yeah, the rudest sacrum ever kept going out without leaving a note. He just not raised well. No, that can't happen, but it feels like it does. It feels like a part of you is now, 4 feet away from where it should be, and that is most likely more to do with tension and some physics and like what muscles are holding more than they need to and what's loose and flexible and what's guarded than a bone being out of alignment. But I totally get and believe when someone says it feels like my pelvis is out of alignment, that it feels like their pelvis is out of alignment. But in the absence of trauma, no. And that's a hard one, right? Because there's people still out there practicing and teaching and saying, if you do this right assessment, we can tell whether your pelvis is rotated anteriorly or posteriorly, and we measure all these things. I used to do that constantly. I was a massive, let's check your posture and your alignment and do all these muscle energy techniques to reset your pubic symphysis and all this stuff, right? I was really good at that. I don't do that anymore. Still, people seem to get better. And
do you find, what I find also is then the patient and the client really fixates on that.
They get scared again and think, well, if I go up too many stairs, then my pelvis will go out of alignment. It's like, hopefully constantly, as you move one leg or back and forth, it's part of the movement that's normal, but you're not that fragile. That goes back to that fragility. The other thing is that if you really feel like someone needs those muscle energy techniques or manual therapy techniques to put them back in, then I think there is a requirement to teach the person to do that for themselves. Because there are a lot of self-treatment things that can do that. It is mean to say, oh man, be careful on this holiday weekend. You might sit on one of those foldable chairs and that'll totally twist your spine and your ribs and your pelvis, and everything will come out of alignment and everything will be bad. And then you'll have to come see me for me to put you back in. And as Peter O'Sullivan says, that's very good for business, but bad for health.
Yeah.
It's one of my favorite quotes I've ever heard him say. That no, really, you're better than that, and your posture is not going to necessarily cause you pain. And 2, if something feels like that, I can show you how to self-treat to put it back, even though it didn't go out, but that sensation is accurate.
Right. And so what do you say then to the patient who says to you, well, then why am I feeling like it's out?
Because they're feeling like it's out. So sometimes I'll say, like, if you've ever been walking and you feel like something just got on your arm and you look down and there's nothing there and you brush it and then that feeling goes away, sometimes that's just a sensory oddness, or sometimes it's things just aren't right. Like you are standing a little hitched to one side and you think, I feel like one arm's back further than the other, and you look in the mirror and go, oh, because yeah, I'm standing like that. Hold on, let me do the opposite and stretch a little and maybe try and find a middle that feels even. I don't know. We do get stiff. We grow the way we use ourselves, and I think that's more accurate than that there's a particular posture that's awesome. It's, are you living in a way that maintains that range of option of flexibility and movement, or have you limited yourself to just a couple and then you find yourself having to reach for something? You're like, nothing moves in that direction because you haven't been doing it.
That makes sense. Okay, so that was number 4. What's number 5?
So I'm going from a list of 10. Oh, number 1, it is never normal to leak.
Yes, I was waiting for that one.
Number 1, never normal to leak. You can jump and laugh and run and cough and do all of those things, and everything should stay inside where it belongs. That's something that is really well backed up with research, that there can be help for that, and often make those symptoms just go away. It is an interdisciplinary event, so there's urologists or urogynecologists, and pelvic physical therapists, or sometimes nurses, that are involved in helping that get better. And there's more and more work in the fitness industry of good information. There's a lot of not good information about incontinence, but there's more and more good stuff out there that's getting knowledge to people. Groups like the Women's Health Foundation have a mission to get education to young girls to say, it's not normal to leak. Here, let's us show you how your body works and how to help yourself. And that's
because what I hear often is, well, I had children, so this is just normal. And so when I can't jump on a trampoline with my kids, if I go to work out, I have to put a pad on because I know I'm gonna leak.
Always wear black because then no one can tell.
Right. And I always say, like, it may be common, but it's not normal.
And it's not necessary.
Yeah.
And someone, I don't know who said this, and if someone's out there who said this, tell me and I can credit you. Because I always say, I don't know who said this. Said that if your roof was leaking just a little bit, you wouldn't put a really pretty bucket in the corner and decorate it and say that's good enough. You would take care of it. But we do that with all these, here's your pad, do this thing, that's okay. Here's workarounds, which I think are great. And there are some products that can give people the confidence to keep exercising. But in the meantime, go see a health professional that can help you not need those products, so that that's not a permanent solution. It's a temporary fix while you take care of the problem. And it is a problem. And we talk a lot about urinary incontinence, but fecal incontinence is one of the hardest things to deal with. You can get out and about when you're leaking urine and people don't necessarily know. But if you're leaking stools, you stay home. So then you aren't exercising, you aren't going to church, you aren't going to your social groups, you aren't going to your kids' stuff. You just lose so much of your life. And there is help.
Yeah, and I think it's important for people to know that there is help for that. So just get in touch with your doctor, your nearest pelvic health physical therapist.
And there may not be a good person in your area, but get a hold of the people closest. So the section on women's health, find a PT, might not have someone in your area. Call someone close. They may be able to help you find someone in your area, because not everyone is listed.
Good to know. Good to know. And so now those are sort of our top 5 pelvic health myths, which I think were wonderful. And I'm so glad that you said, I was waiting for you to say the leak ones. If you didn't, that was my number 1.
Like John Leno list. Number 1.
Number 1, not normal. Okay, so now let's talk about treatments for some of these common myths. Obviously, again, this isn't individual treatment advice, but these are, let's just talk about the principles behind them and how maybe following those principles can help the patient or help the therapist help their patient.
Okay, I love this. This is like a quiz because I have nothing written down. So this is.
Oh, you don't need anything written down. You're a pro. Come on.
Same thing would say if a patient asked me this, it would be like, well, for incontinence particularly, that needs a little more investigation because it's not necessarily a weakness issue. And we talk about it sometimes like, oh, just do Kegels, strengthen the pelvic floor muscles, and that will get rid of your problem. But that is not necessarily true. You may have very strong pelvic floor muscles, but get very technical, an autonomic nervous system that is not regulating the bowel and the bladder well, so it might be a bladder issue, not a pelvic floor issue. Or your pelvic floor may be so contracted that it forgot how to relax, so there's too much tension and your bladder or your bowel is getting a little discoordinated because it has to try and overcome that tension. So it's not as easy as just strengthen it and it will be fine. It needs a good, careful assessment to see what does this person need. And then you get that and you practice it. But the literature says within 12 weeks, if you're on the right kind of program, I think it's 86% of people should see an 80% resolution of symptoms. And that's pretty good.
That's awesome. Better than 50-50.
That's right, better 50-50. So that's not bad, but that does mean you need a good assessment, and you're probably going to need an internal pelvic floor assessment and possibly some medical tests like urodynamics or manometry or something if it's not very obvious on assessment, then there needs to be more assessment. So the short answer to that is if you go see someone, you should expect improvement within a week or two. Not completely gone, but a trend in the right direction. If that's not happening, find out why. And that might require some more medical testing or a very complete internal pelvic exam. And this is true for men and women.
Actually, I'm glad you just said that because that was one of my myths. We're going to back up to just one more myth.
Get an extra myth.
I'm glad you said that. And the other myth is that only women have pelvic health issues.
Yes, that's so not true. Men, women, really across the gender spectrum, as I think I have learned to say from really brilliant therapists like Uchenna Osai is fantastic at talking about all of the different expressions of humanity and sexuality and pelvic anatomy. Anyone can have a problem, and they can all get help.
Right. You just have to go and find the help. And don't be embarrassed about going to find the help, whether you're...
And that's a really important part, right? So sometimes people don't talk about it, and guys aren't likely, girls either, to say, so guys come in and saying, you know, my left testicle hurts is a hard thing for them to go tell someone, or the end of my penis hurts all of the time. And once you get cleared for STDs, and they say, because it's the first thing they'll check, is, well, there's nothing wrong with you. Yeah, except for there's something wrong. You have to find the right provider. Just don't stop looking. And it's distressingly long between when people start with symptoms and when they get to a provider that can point them in the right direction. Too many people are just blown off. Like, well, that's normal. Guys get that. Just like, well, you had kids, you're going to leak. Guys get, yeah, well, you know, that happens. It's stress. Or it's your prostate. Here, go on antibiotics forever. Guys have problems with it too.
Yeah. Okay, great. I'm glad that you mentioned that because that was something that I definitely wanted to let the listeners know exists and if you are a man and you are feeling pelvic pain or issues with your genitals, to definitely investigate.
And just because many providers call themselves women's health physiotherapists or physical therapists, that doesn't mean that they cannot help men or transgender issues or anything, children, whatever. You just need to find the right person.
Perfect. Okay, so let's get back to some treatment options again. So
assessment.
we spoke about treatment for incontinence issues, which is a whole webinar in and of itself. But just know that it's there. You are more likely to see improvement if you get to the right people, and don't just write it off as being normal.
Right.
And try and find sort of the root cause of the issue, which may require you to have additional assessments and testings. Is that correct?
Correct.
All right. So again, doesn't sound that difficult.
It does take time.
Takes time.
It takes persistence. And it takes a little bit of armor against people telling you that's normal, just deal with it.
Got it. Got it. Okay. So what else? What are some other treatments that maybe are overly complicated?
Pain.
Or when described about being overly complicated, and how can we simplify that?
I think pain's one of the biggest ones. And in the pelvic world, you can have bladder pain, you can have, just for women, there's 7, just off the top of my head, names for pain in the region between your pubic bone and your tailbone. There's not very much space, and there's a lot of different names for what's going on depending on which piece of anatomy hurts. To be fair, sometimes those are dermatological issues that need to be ruled out. Sometimes it's injuries that happen during childbirth that need to be corrected or supported. Sometimes it's a hormonal issue that needs some support from medication or education. But sometimes it's pain. And I am of the belief that the body part that is in pain can still be treated regardless of where it is. That elbow pain and knee pain and toe pain and labial pain are still affecting the system that is involved in pain, and we need to address that. And that gets back to the don't tell people they're going to need this special cushion forever, because it could be a neuromuscular spasm that has just sort of grown and everyone unweighted the area, which you would never do with a foot cramp. If your foot was cramping, you'd load it and you'd stand on it. But people get these spasms in their pelvic floors or their rectums, and they get off them and lay there and wait for the pain to go away sometimes. And sometimes that's what they're told. And I think that overly complicates it. So to have providers a little less afraid of dealing with pain in the pelvis, not causing pain, but also not being afraid of it, respecting it, I guess, and coming up with some functional ways for people to manage their pain while they do the movements and the exercises and work towards getting better. That was a really long answer.
That was great. And I think it's important that you made that comparison between, let's say, the knee or the foot and loading up that area, which we would do for knee pain, hip pain, shoulder pain, foot pain. And I think when it comes to pelvic pain, and I feel the same way when it comes to back pain, all of a sudden people forget that those loading principles that are there for the rest of your body can be adapted for the pelvic area as well.
Strength and conditioning principles hold true. I mean, that's the body and how it responds, and it's still muscles and ligaments and nerves, and they respond like they do everywhere else. A little bit extra protection, but that's cool. It came like that, and it's good for it. Sarah, my business partner and friend, said something about that there should be a run for back pain, which would ironically also probably help back pain, because so many people try and rest themselves better, and that's just not, outside of a broken bone or mono, that's probably not the right answer.
Right. So what are some examples then of how you would load the pelvic region?
Oh, this is stand-up comedy worthy. I'll try and refrain. There's a very well-respected in the pelvic health world old technique of using dilators, like a dilator set, for inserting either rectally for gentlemen sometimes. Certainly women use it more vaginally, of a progressive set of dilators that three-dimensionally expand the tissue, or expand the space in the vagina to put stretch on the tissues. And that's really helpful. It can be really, really challenging. And there's great ways to grade the exposure to that. But then once you can do that, that doesn't necessarily reproduce the act of penetrative vaginal activities or rectal activities. And there needs to be a really creative, individualized way to get from, hey, I can mechanically work on these tissues and now they can tolerate touch and pressure and movement. That's a large leap to go to then involving another body and intimacy. So that's a lot more challenging than working knee rehab sometimes. But it's totally doable, and there's good people all around the planet that have had some success with some graded exposure, and there are counselors that work with couples to get back to intimacy. And I think the biggest part about working in pelvic health is having a good team around you. It does not need to be in the same facility. It doesn't even need to be in the same state. Because now with telehealth and email and Skype, you can answer questions and help people come up with solutions from far away too.
So I think what I'm hearing is that it's important not only for the therapist or the practitioner to have this robust team when dealing with, more complex pelvic pain issues, but if you're the person with the pelvic pain issues, it's important for you to seek out this team. So if you're working with someone and they haven't suggested maybe, a sex therapist, or they haven't suggested maybe a pain psychologist or something like that to join your team, then it might be something that you want to seek out for yourself.
If needed. A lot of people come up with the solutions themselves. I have learned as much from patients problem solving as I have from professionals lecturing or papers. Mm-hmm. Probably more sometimes, because that person knows what they like and they know their partner. And that's always fun. But I think when you talked about principles, I think at first we need to, if you have pelvic pain and intimacy is painful, then first we have to make that not true and calm it down. I tell my patients we're going to make everything boring, because pleasure is on the other side of boring. So first it needs to not be scary or threatening or hurt, I think. And then start to reclaim pleasure and intimacy and confidence and arousal. And that is possible. Some people it happens really quickly. Some people it takes years. But again, you should be seeing progress towards it.
Great. And so we've got some loading and strength and conditioning principles and graded exposure principles. What are some other, let's say, prevailing principles when it comes to treating pelvic pain or pelvic dysfunction? Or what are we missing?
I think we have to look at expectations and their beliefs and what they think is going to happen. There's an interesting part of the pelvic floor and arousal is that if you're how threatening you think it's going to be to get the, specifically for arousal, if you want the blood flow for a man or a woman that is going to make orgasms, erections, the engorgement of the clitoris, all of those things that are normal in human sexuality, if that's going to happen, then you need to be able to tolerate increased blood flow to the area. But you also need to have a belief that it's going to be okay, because your body's really smart. You are really smart. And just like touching a hot stove, if you know that that's hot, you're not going to touch it. You're just not. If you think it's hot, you're still not going to touch it. If you think that arousal is going to be painful, you're probably not going to get aroused because you're smart and you're not going to do that. So we have to work on the thoughts and beliefs and expectations. And I always will ask people when they start to have success and things hurt a little less or less hurts, or they did something and it was okay, then I will ask them, how many times would that need to happen for them to think that that's their new normal? And for the answers all over the map. Some people are like 7, and they know. Some people are like, just like never. I don't think I'll ever believe it. That answer usually changes, but some people will come up with very like 4 months and 12 days, like they know how much success they're going to need to see before they think that's what's going to happen. And I think we need to know that. But that goes back to sports and conditioning and training with athletes. The athlete has to think they're going to do well. Because if they think they're going to lose, then that gets in their head for the game.
For sure.
It's no different, I don't think, for anything that we're trying to do. And I think when you add another person to it with intimacy and sexual relations, that makes it more complicated. Then we can still stick with strength and conditioning and team sports and say, do you trust your teammate? So, do you think you're going to be okay? And do you think your teammates got your back? So that goes into it as well.
Yeah, and I think that all those principles, which are principles that we all use for other parts of the body, can certainly be applied to the pelvis. And it doesn't have to be as complicated as people make it out to be, or as scary as people make it out to be, right?
Yeah, like you can't talk about it and you can't say the words and come up with different words for it. So we say penis and vagina and labia and all the accurate parts because that's what they're called.
Fair enough, because that's what they're called. All right, so let's kind of leave before we move on to one other thing that we want to talk about before we get off this call. What are the main talking points you want people to remember from what we've spoken about today?
Don't steal someone's hope, and don't let anyone steal yours. And to both people dealing with pelvic issues and providers who help people, I would say, have some trust that those areas are as robust as the rest of the body and that you're not broken. It's going to be hard, but it's not impossible. And it needs to be individualized to the person that you're dealing with and their thoughts and expectations and their goals so that you can make it meaningful.
Sure, just like anywhere else.
I call it, therapy. Yeah.
Yeah. AKA physical therapy or physiotherapy. All right, now, before we get off, we just want to plug one more thing. So if you want to talk to Sandy or talk to many, many women involved on the section on women's health, which is part of the APTA, they will all be, I'm now a member of the section on women's health.
We're just taking over everything. That's it, to everyone. We want everyone. So
we will all be on Saturday, September 23rd of this year, which is less than a month, 20 days from now. We will all be gathering in New York City for the Women in PT Summit. And I think, yeah, so go, and we'll have that underneath this as well. You can go to womeninptsummit.com to find out more. There's going to be tons of therapists there from this section on women's health. So if you're interested and you want to network and you want to meet and you want to hang out with these women and men, then definitely come to New York. You can come live. We still have about 10 tickets left to sell, which is not a lot. But if you can't, we also have an online version. So the online version is you become part of the Women in PT Summit 2017 Facebook page. You'll have access to that page for the entire year. Not only will you get everything from the conference, but we're also going to be doing interviews and special events throughout the year inside that Facebook group as well. Yeah, it'll be great. And there are so many people with so much talent and different ways of problem solving. It's worth talking to as many people as you can. One thing about pelvic health therapists, if you can get us talking, it's really hard to get us to stop. True. Because we like this stuff. It doesn't matter where you are. Dinner, Disneyland, a bar, it doesn't matter. Sorry, there's some sirens going off behind me right now, which I'm sure everyone can hear because I'm in New York City. Between New York and Chicago, it's been completely silent for most of the calls. Amazing. I know, it is amazing. So yeah, we're gonna have, and Sharon Dunn's going to be our first keynote, and we're really looking forward to what she's going to say. And then we have New York Times bestselling author and executive leadership coach Lolly Daskell as our second keynote speaker, which is going to be amazing. And then in between, we've got men and women on panels ranging from entrepreneurship to working outside of patient care, using your degree in a different way. We've got TED Talks, well, our version of a TED Talk, which we call a Power Talk, 6 of those. And it's sort of for, not only for women in the physical therapy world to feel like they're empowered and inspired to step into leadership roles, but it's also for the men who want to support them. And I think that's really important.
Yes. I think getting everyone talking and helping together can really make some shifts into the way things are done and managed, and you can raise a whole new generation of PTs that have information that we didn't have.
Exactly. So we're sorry. So at any rate, I think there must be a fire across the street or something.
I don't see any flames behind you, so I think it's safe.
No, I don't see any behind me, which is a good thing, but you know, it could be in my building for all I know. Mariah said she can't wait to see Sandy at the San Diego Pain Summit in February.
You'll be there too, right, Karen?
I think so. I have to make some serious decisions, but I think I will be there. Okay. So on that note, we will have some of the resources and the people that you mentioned, Sandy, if you can put those, we'll put those underneath this broadcast, as well as, like I said, the URL to the section on women's health, the URL to the Women in PT Summit, and anything that Sandy thinks should be there.
Oh, wow. Carte blanche. No, I like it. I like hooking to the Women's Health Foundation and the work that they do with public education. And one of the people that I learned the most on intimacy in therapy, helping people get back to it, would be Tally Rosenbaum. She has fantastic resources and just one exceptionally talented healthcare provider.
Awesome.
So I'd like to link her stuff on there too.
Perfect. So we'll have all those links right underneath here. So Sandy, thanks so much for taking your time out on Labor Day here in the US to come on and talk about pelvic health stuff. And hopefully we cleared up a couple of myths for people and we're able to make the idea of if you have pelvic pain, if you have a patient who comes to you with pelvic pain, of making it not quite as scary and not quite as complicated. So
remember to ask. And if you don't treat it, refer to someone who does.
Yes, always refer to someone who does. Don't fake it. It's not a fake it till you make it kind of thing when it comes to this stuff. So refer out to the people who know. So Sandy, and we'll link to Sandy's page, to Entropy's page, and things like that as well underneath. So, all right, thanks so much for coming on this afternoon.
Happy Labor Day, all.
Yeah, happy Labor Day, everybody. Thanks for tuning in. Bye.